Well, good afternoon. It looks like we're at the top of the hour. We do have a few more people joining us, but like I said earlier, we do have a packed agenda, so let's go ahead and get started. Thanks everyone for joining us. I'm really excited to get this started. It seems like we were on a roll and we were just getting the ball rolling, and COVID came in like a wrecking ball and kind of destroyed it all. So put us all on pause. So I'm really excited about getting this started. If you'll take a few minutes to go ahead and chat in your name and organization in the chat box, that'll help us know who's here as we look through it afterwards. And I look forward to getting started and hearing what we have today on our agenda. Roger and Tina will be our facilitators for today's meeting. So I'm going to go ahead and turn it over to Tina to get us kicked off.
Roger, do you want to do a review of agenda and learning objectives first before I get into the measurement piece?
Happy to do that. So based on the interviews that we did a couple of months ago and the dialogue that's been ongoing, we heard from the group that optimization of telehealth was a high interest, as well as the focus on diabetes and depression / anxiety. So today we're going to be delving into that in the context of the population health LAN. So we're going to try to connect some of the dots from the prior work. For those of you are new, help clarify some of those expectations. And then we'll be sharing some resources for you to help you with your telehealth efforts. Want to go to the next slide, Tina? So what we want to make sure is that you're clear on the expectations moving forward, what this is all about and the work that we're going to be doing. We'll be describing use of telehealth to tackle diabetes and depression anxiety care. I'm hoping we'll have time for 2 small breakout groups with an exercise where you'll be able to step back and think through based on some of the content, and then we'll identify next steps and expectations moving forward.
Okay, thanks, Roger. So I am just going to take a few minutes of your time and go over some topics that relate to measurement for the WPCC, but these are also going to be directly applicable to the population health LAN. So I'm going to go over at a high level purpose of measurement, some of the expectations, and what supports you can expect. But I'm also going to make sure that this is the focus of our quality improvement affinity group meeting this month on October 28th, so that if you have more questions and if you want to walk through any of the components, we can spend more time digging into it then. So just really at a high level, I think probably some folks are familiar with the fact that we've been talking about streamlining the measurement process as well as what is required for measurement as a member of the WPCC. And these changes have been made after some months of listening through the site visits, talking with members of the WPCC or sites to ask, how can we really focus over the next year and change left in the WPCC work, and how can we really create a measurement system that will help your site towards learning, action, and driving measurable improvements. So really, when we redesigned the measurement approach, these were the things we had in mind in terms of the purpose of supporting your site learning and action to drive measurable improvement, supporting and enabling learning between sites, all the members of the whole person care collaborative to accelerate improvement, and finally to support organizations to position themselves for a future with value-based payment. Some of you may already be aware that there are 3 required measures that we're going to focus on over the next few months. And then you'll also have a choice of 2 different measures that your site can select, and you can work with your practice facilitator to make sure that it's an indicator that will hopefully align with some of the changes that you're going to work on. So one of the core required measures is going to be hemoglobin A1C pore control. Again, I'm going to go over these in more detail at our QI affinity group meeting, just wanting to introduce them to you right now. Second is depression screening and follow-up. This is NQC measure 0418. And we also have a bit of a change to one of the previous measures that that you probably are familiar with, and this is depressive disorder monitoring. The previous iteration, the NQF measure, was quite complicated and really difficult for sites to collect. So what we've done is attempt to create a bit of a definition that's a little more permissive and a little more broad in terms of how you can achieve the spirit of this measure. So this new sort of definition aligns with the spirit of the NQF measure, enables flexibility in the choice of validated instrument to monitor depression symptoms. In terms of collecting and reporting information, we're going to ask for all sites to create an improvement charter. This is not really rework from having created a change plan. Anything that was on the change plan will probably be directly relevant to your improvement charter, but it'll be much more focused, much smaller. And we have a template for that. With the quantitative measures, the 3 required ones and the 2 choice, we have now an Excel template that we're going to ask teams to use. And then with the qualitative reporting, we have a Word document. So rather than using the portal, what we heard is that a simpler method could be to submit these 2 documents, and hopefully the intent of this also is to provide for a system of collecting your quality measures that is something that you'll be able to sustain well after the Whole Person Care Collaborative ends. Support's available. So there's the charter. We have a sample and we have a template that we'll be sharing soon. Of course, your practice facilitators, Wendy and Mariah, are available to support you in collecting that data, in defining how you're going to collect it, all the elements of measurement for improvement. And then, of course, look to your change plan. You don't need to reinvent the wheel. This is really just a refocusing and a streamlining of how we're going to report and collect data. So a lot of stuff will still be very relevant from that. Again, that was a super high level, but I just wanted to introduce it now. Again, the Quality Improvement Affinity Group meeting on October 28th, we'll be able to have a lot more conversation about this. Okay, so with that super high level, any quick questions before we move forward with some of the content for today? I see some heads shaken. Nope, no questions. Okay, great, awesome. Of course, chat box available if you do think of some questions, and I will now turn it over to Roger.
Great.
Can I just say, if you haven't already chatted in your name and organization, would you please do so? I know we had a few people join us since that was announced. Thank you. Sorry, Roger, to interrupt you.
Not at all, not at all. Thank you, Wendy and Tina. Let's re-ground ourselves since we've had just a minor inconvenience in the environment here called COVID that's disrupted everybody's world. But we had launched a population health LAN, which was a learning environment where a group of the organizations had come together to collaborate and share and learn from each other on population health management techniques. And our focus was, at the time, we were looking at diabetes and depression as our main areas of focus. And that was based on feedback we'd gotten from all of the teams and organizations in the field that those were their highest priorities. And we continued to meet up until February, March. I think we had a face-to-face in March, early March, and then boom, COVID hit. And we've been on this break period. And as a result of that, we're now here in October, on the 13th here, trying to ramp back up. And so if you look forward on the right-hand side of the screen, there's the October 21st and it says AIM. October, that's October 2021. So if you think October 2021, that's the end of this planning horizon that we're going to be working together over this time. We are still keeping a focus on diabetes and depression/anxiety as our conditions of focus, but all of the concepts and things that we're going to be learning should be applicable to other disease states. So this is continuing to do shared learning, but with a particular focus. And we're hoping that in this journey, you are starting to develop real theories of change. Things that you think, if you really wanted to improve those measures, these are the things that we should be working on to improve them. Now, we provided you with a change package and the change concepts, which are the evidence-based ideas that have shown to work in population health management that could be adapted and applied to your area. So they're a starting point. They're not limited to that, but they give you a roadmap. If you don't know where to start, you could go back and look at those things. And the hope is the way to optimize this learning experience is as you move forward, you're going to be doing monthly reporting, not quarterly. The big difference there is that when you're reporting on a quarterly basis, it has the feel of a project. When you start to move it to monthly or weekly, if not even daily, it's starting to build quality into your daily work. And what we see from advanced organizations is that they look at their data constantly and they're using it to drive their planning, their engagement of the people they're serving, and to adjust the strategy. So we're asking for monthly reporting. That's going to give us a little bit more sensitivity to the changes that you're making. We hope to see those, what we call moving the dots. Those dots move in those core set of measures. We're asking you to work together and refining your aim, and then on a weekly basis, be testing changes. To be thinking about what do we want to do this week? How can we improve things? To be looking at your panel of patients that are scheduled for the next week, and which of them fall into the diabetes and depression and anxiety arena? What should we be doing with those people? And today we're going to be talking about how telehealth can be adapted to work on those particular conditions. Now, I know many of you have been thrown into telehealth because of the COVID and are in the midst of adapting your strategy. Some of you may have been doing some telehealth prior, and all of that is in flux, and many of you have a lot of questions. I took a couple of high-level questions that typically come about in the telehealth arena. I'm going to talk about those today and give some examples of strategies, but I'm going to make the offer to the group, if you'd like to have an office hours, which would be just an open, no agenda opportunity to bring any telehealth struggles, I'll be happy to set that up and take advantage. So chat in if you want to take us up on that offer for telehealth office hours. You don't need to do that now. You can do that at the end of the call. I will also, as a follow-up to this, be providing you with a series of resources to help you with your journey. So feel free to chat in with any questions on what we're asking you to do, but let's move on to start to dive into telehealth. So telehealth, the COVID pandemic has been fascinating because it's forced people into a whole variety of alternative telehealth models. And there's some work that's been going on in clinics. There's some work going on at home, between clinics and the home, and there's some work going on in the community. Unfortunately, a lot of organizations that were thrown into this approach telehealth kind of on the backs of the provider. We've got to get our providers on the phone with these patients or through a televideo in some way, whether we're using Zoom or an existing platform, an alternative platform. And a lot of it was on the backs of the provider, which turned out to be pretty challenging for many of the organizations. And there's a fair amount of failure rate we've seen around the country of groups struggling with that. There are others that integrated telehealth into their workflow. I'm going to talk about a couple of models there. Some didn't miss a heartbeat. They looked at telehealth as simply another type of appointment and built it into their regular schedules. Others have used telehealth for social distancing. I work with the Indian Health Group, and they have a very robust telehealth model, but very little of it is in the home of the people they serve because there's no bandwidth for the people they serve. So what they did is they used telehealth in their clinic. And so they also found that there were some strong cultural things Patients didn't want telehealth. They wanted to come to the clinic because that's also their shopping day. It's the day that they get to socialize with other people. So what they did is they used telehealth in the clinic. So the patients arrive, have a clinic visit, but the care team are all on video engaging the patient. So that's a very different concept. Now, some of you are already doing that in some ways with your patients. There's a facilitated model where they found that, especially with some of the older population, where there was a need to have an extender go into the home and actually work with the patient, whether that's a community health worker or a care manager, could be a community resource, it could be EMTs, others that go into the home, and the care team is in the clinic in a facilitated visit engaging the patient. And then there's the community hub model where the providers are in the clinic, the care team's in the clinic, but they're engaging a whole group of patients, the group visits for behavioral health, for diabetes, for other conditions. It's very common now. I've got a few millennials that have been moved in the back home as a result of COVID, and they're on group visits doing their exercise classes with colleagues and friends. And how can that be offered in a wellness model within your clinic? There have been COVID-specific group visits that organizations have been using to address some of the questions that people have in the community. And then there's the hospital in the home model, where increasingly there's the realization that with remote monitoring, we can start to change the care model and start to look at how things can move more into the home. The Institute for Healthcare Improvement has an initiative called the Office Visit is a Dinosaur, and suggesting that we're going to start to move much more into the community model, where we're going to be treating patients in the home. I was on a call earlier in the day where the suggestion was that hospitals are going to become very intensive ICUs, with most of the care actually happening in the home or in the community, and only really the sickest patients in the hospital. And so that has lots of implications for our role in primary care as we think through. So I want you to be considering these models as you think of the different work that needs to be done to support our patients. Please go ahead, Tina. There's a maturity model. This is a consulting firm, Manic Consulting, that developed a maturity model in thinking through what is telehealth going to look for, from the very basic reactive model to a very advanced strategic model. And I would suggest to you, as you work through this population health LAN, you can become much more strategic in your approach and be thinking about how we can start to integrate. Even if your organization doesn't have a strategic, a clear strategic plan for this, you can start to formulate that at your panel level and begin working with your individual groups of patients to help inform that broader strategy as an organization. So think very strategically, not just how do we react to COVID, but as we look at depression management, anxiety, as we look at diabetes, what aspects can we move to telehealth that's going to improve our access and also the engagement of our patients in care. Next slide, please. So there are a variety of models out there. Some organizations are only doing televisits, and this would be telephonic. And go ahead and chat in if you're with a T, if your organization is only doing telephonic. Some organizations are doing block scheduling, where the time of the televisit is slated for a whole block of time. That could be mornings or afternoon, and then the regular office visits are handled in the other time. And then there's the hybrid model. And the hybrid model is where you have telehealth mixed into a variety of approaches. I'm going to show you some templates for that in a second. So just go ahead and think about how you're doing that with your own organization, or maybe none of the above. You may have a whole new different model. So I see a couple are doing telehealth only, one PC, some behavioral health. Yeah, it's very interesting. Around the country, about 35 to 40% of telehealth is in the behavioral health arena. It's been the biggest adopter of all the medical specialties, at least in the United States. So we see some hybrid models and some telehealth models, televisit only. Okay, next slide, Tina. So as we think through these different models, the first thing is that one of the best practices we've learned is that it's very important to develop some visual control tools for our staff to decide on how to book our patients. So this is an example from Fenway Health Center in Boston. This is a clinic, a primary care clinic, serving a very wide Medicaid population predominantly, and a lot of the HIV community. And they developed a protocol for their schedulers, for their staff, that spells out what are appropriate for telehealth and what are not appropriate for telehealth. And I'll be showing a methodology here in a second on how to go about doing that. But the bottom line point is, for your practice, make sure you have those tools in place where you're not getting bombarded by your staff each time there's a call, so they have clear guidance on what is appropriate, what isn't appropriate. What we've seen is that, next slide, please. A methodology, Cambridge Health Alliance in Boston, another Boston-based group, developed a multidisciplinary care team that sat down and started thinking through, what do we need to do with telehealth? Let's have the various members of the care team participate in that. And let's start to figure out our time slots. How are we going to build this forward? In their environment, they developed two basic options. One is scheduling providers for 5 20-minute slots, and having the flexibility built into that with some administrative time, so that they're able to catch up on the documentation and have everything they need as part of the visit, so that they're able to get everything done that they need to. The other is much more of an open-ended model, where they let the providers and the care team sort out the time, but with some flexibility. I'm going to show you those templates in a second. They don't do any same-day releases until after 11 o'clock, so those same-day appointments are not held until after 11, giving the care team time to get things in place and engage. And they have a limit on their maximum amount of visits. So this is an example of developing a template for the practice. Next slide, please. What that starts to translate into, you see here, this is an environment where it's all almost telehealth. They're in the clinic doing telehealth, but they have some same-day holds. You hear that they were handling the urgent patients coming in for the same day. You notice the red is admin time. So this is where they're building into their schedule the admin time for their providers to catch up and the care team to catch up on any follow-up needed for the patient and moving it forward. So you notice there's also in this schedule on the left, there's some open days. There's nothing scheduled on a Thursday. That's because you'll see they extend their hours in the evening and they have a Saturday schedule. So they're accommodating a 2-week schedule that optimizes that for the care team. Next slide, please. This is the second option. I do what I want when I want. And this gives the care team the flexibility, but they're just basically building it into a whole slate of visits, and then provider admin time built in at various pieces for to catch up. But this is really left up to the providers and the care team to really manage. They're dictating the length of the visit and juggling the patients coming through. They know how many patients are scheduled in and how to balance all of that. And I know there's some questions about the role of other members of the care team that we'll get to here in a second. Next slide, please. And this is a very advanced integrated model. This is probably one of the national benchmarks in the United States. It comes from South Central Foundation in Alaska. They've been doing telehealth for many years, and they redid their population health model. And as part of their population health model, they stepped back and said, you know, what is appropriate for us to be doing through telehealth? We can do a lot more of our care coordination, care management. We could do a lot more of our screens, our PHQs, a few other things. We might be able to do more of that telehealth and offload that from the visit so that we're really optimizing the time in the clinic. And what they found through their model of restructuring all of this, that they're able to reduce actually the number of face-to-face encounters through that model, but they've dramatically increased the number of virtual contacts by all members of the care team. So they have pharmacists, social workers, dietitians, other members of the care team reaching out and engaging the patient. Now in this template, the orange represents pure telehealth offsite. So in this case, they're allowing the providers to be working from home, doing only telehealth in this model, and they use color coding to be able to differentiate when they're on site, when they're not on site. So just another alternative model and technique to be able to see the scheduling of the providers. And feel free to chat in with questions as we move throughout here. Next slide, please. It's very helpful to codify your telehealth visit workflow. This is very small. You'll get hard copy of this so you can drill down and see it in more detail. But this basically outlines the steps in the process, and including the warm handoff to behavioral health provider where that's appropriate and how that's done with the patient. So being very clear on what the steps are for all of the staff. And so it's not ad hoc. It's a very clear visual image, and as staff come and go, they're able to adapt into the model and know exactly what their role is, what the expectations are, and how they move things forward. Next slide, please. So that's the common questions that come up about what's the best approach for scheduling. This is very much an issue of local context and situation. And the best practices really span environments. It's hard to say what is the best practice. In general, what most people are finding when we are in a time of having to change with PPE, that block scheduling tends to work out a little bit better because you're not changing in and out of the materials necessarily all the time, and a little bit easier for the care team and the providers to handle. There are care teams that have overcome that and very seamlessly manage a telehealth visit, and they use a room where they're able to go in, and they know that patient's scheduled for telehealth, and the next room has a live patient. They go back and forth as seamlessly, and they're very comfortable doing that. You have to work that out for your own situation. But in terms of how is rooming done, what we find is most of the organizations that have best practices have basically adapted their care model to include telehealth. And so the medical assistant is still doing what they did before, conducting the rooming, doing certain screens where that's appropriate. Some screens that they've determined are not appropriate. This is Cambridge Health, where they would prefer to do certain pieces like other things like the MOST and the healthcare proxy. They would prefer the provider doing that or another mechanism. But the staff get in there and tee the patient up, can get some of the other consents that are needed, make sure the patient's comfortable with the telehealth. Where you give advanced warning, and I've heard some practices from some of you, calling the day before, sending a reminder the morning of. That's reduced no-show rates dramatically. For most organizations, they have seen a decrease in no-show rates. The decrease in no-show rates in behavioral health has been very dramatic across the board in organizations around the country, with telehealth being accepted. So the basic concept here is to try to figure out how to build it into your workflows where possible and adapt it, but again, use those visual tools and scripts to help the patients with that. And we'll point you to some resources on scripts and other activities. Next slide, please. Again, the provider visit, this is from Cambridge Health, again, templating the provider visits. It's very clear what the provider is doing, what the role is, what the key steps that they need to do in their medical record, and giving them the proper guidance and cheat sheets for the coding based on their state laws and regulations for telehealth and the local circumstance, but being very clear and providing that tool and cheat sheet. Some have turned this into a checklist that the providers use, so they become very used to those telehealth processes and flow, and that increases the efficiency as they move along. Next slide, please. So there's a whole series of resources we're going to turn you on to. We have a telehealth change package we're going to make available. This is looking at concepts, again, change concepts around optimization of your telehealth systems. We're going to provide you some workflow examples of telehealth. I have a couple of those. There's an interesting article from the New Jersey Catalyst on improvement processes for telehealth. There's a self-assessment tool from the Mid-Atlantic Telehealth Resource Center you can use to look at your overall telehealth program. I have an FAQ that we obtained working with 32 organizations from around the country in telehealth and what their most frequent questions are. So we'll provide that to you. And then there's a free open source portal on healthcarecommunities.org that has resources and a forum where people can post questions and materials. So feel free to jump in with additional questions or comments as you move forward. So that's kind of a broad overview of telehealth as it's evolving. Let's now drill down in the context of managing your conditions. So as you last remember when we left off, next slide, please. Our actual last, I think, LAN webcast covered some workflows around diabetes and depression management. And in this, we shared a tool, a swim lane diagram on diabetes, and there's some classic measures on the top. These aren't necessarily the measures that we're using, but from this organization, those are the measures they were tracking. And for those to move those dots, what they identified is who in their organization needed to do what and when did it occur in their organization. You can apply this same technique to be thinking through your diabetes management in your clinic and adapting the telehealth component to it. And how does that workflow fit in to what you're thinking about in your organizations? So remember that these resources are made available to you at the last call. Next slide, please. So in the context now of depression and anxiety on the last call, next slide, please. We had both Confluence and Cascade present their workflows on how they were approaching behavioral health and their assessments and screening and incorporating into their flow. Next slide, please. So this was from Confluence that presented. They had their PHQ workflow for, again, for screening and think it through. So be thinking about how we might do this in the context of telehealth. You can go to the next slide. Again, this was from Cascade talking about their model for telehealth. So this is about really understanding what you're going to be working on in diabetes, what you need to be focusing on in depression and anxiety management, and what is your care model? What needs to be done, when and by whom? And then how will telehealth fit in and support it? And what we'd like to do is take a couple of questions and see if there are any questions, and then have you meet in small group. We'll break out into 2 breakout groups. We'll have the behavioral health organization meet as one group, and we'll have the primary care meet as another group. I'll ask Wendy Bradley if she's kind enough to go with the behavioral health group and help facilitate, and I'll work with the primary care group. And then next slide, please. We'll move. The next slide. We'll move you through a tool here and ask you to start to have a dialogue of what might you be able to do when you think about your care model for diabetes or depression. What aspects of wellness and prevention are you doing now or not doing now that you could be doing through telehealth? If groups are out there offering exercise classes for people and doing that on a fee basis, why isn't that part of your behavioral health or current diabetes model? It may already be, but how can you incorporate that potentially in your model? For urgent care, can you create that access for very quick access to urgent care through your telehealth? For your chronic illness, how often do you want people to be coming into your clinic for their diabetes or their depression management in your care model? If you have a structured depression model that might have 6 to 9 visits over a period of time, how's that going to be done, and how much of that could be done through telehealth in your future model? If you're teaching self-management to patients on how to do self-care, and you may be using peer models in that, how can you support that through telehealth? And then the last piece is the care coordination and care management. What can you do through emails and reminders? So let's stop and see if there's any initial questions. And then otherwise, we're going to ask you to break into your small groups and set up the breakout rooms. So 2 breakout rooms, one for behavioral health and one for primary care. We'll ask you to work through this worksheet. Wendy, I sent you the slide deck, so you should have your slide. I'll be using my slide in our group. And then we'll ask you to work through that for about 20 minutes, and then we'll come back together and report out. What did you learn from each other? What are some of the initial thoughts? And how might you incorporate telehealth into your work plan? So any questions before we break into a small group? You can chat in or raise your hand. And if there's none, that's fantastic. We'll wait a few more seconds. All right, then let's break into the breakouts. Can we go ahead and launch breakouts?
We can. There's actually a new option that you can choose. So I've labeled the breakout rooms, primary care discussion and behavioral discussion. behavioral health discussion. I'm going to open all rooms right now and you should be able to choose. So here we go.
So you get to choose the room that you want, and you will be directed, just click on it and join the room that's appropriate for your interest.
If you need any help, just let me know and I can also assign from my end.
Hey, Wendy, can you repeat how to get to another room?
It should be on your screen to join either the primary care discussion or behavioral health.
I'm not seeing that.
I don't see it.
Okay. All right. Let me just call out.
I also need help. This is Heather Massart. Mine never popped up.
Okay. Just tell me your name and what room you would like to be in.
Heather Massart, and I would like to go to primary care.
Okay. Next person.
Shoshana Palmentier, primary care.
Okay. Next person.
Haley Middleton, primary care.
Next.
Tom Thompson, primary care.
Primary care.
Got Tom, and who else was talking?
Christina Harville.
Primary care. Okay.
Jamie Hillier, behavioral health.
Jamie Hilliard, behavioral health.
Hey, Wendy, it's Christina Clark. Can you throw me into primary care?
Gotcha.
Samantha Cardique for behavioral health.
Gotcha.
Mary Louise Jones, primary care.
Okay.
Behavioral health.
Okay.
Sarah Van Horn, behavioral health.
Lonnie, are you primary care?